Welcome to the Fracture Prevention Central webinar, Setting Up Your Fracture Liaison Service Program for Success. Steps, materials, FAQs, and guidelines you want and need. Fracture Prevention Central, brought to you by the National Bone Health Alliance, is made possible through support from Armgen, Inc. and Eli Lilly and Company, Inc. I'll now introduce you to Debbie Zeldo, Senior Director, Clinical Programs for the National Bone Health Alliance. Debbie, welcome. The audience is yours.
Thank you all for joining us today. We're excited about today's webinar and have a great lineup of speakers who are ready to share their expertise, their tools, and answer your questions on setting up an FLS. As many of you know, one of the central goals of NBHA is to sponsor the Fracture Liaison model of care. The FLS is a proven, coordinated preventative care model which operates under the supervision of bone health specialists and collaborates with the patient's primary care physician. An FLS coordinates post-fracture care through an FLS coordinator who ensures patients who fracture receive appropriate diagnosis, treatment, and support. Patients with recent fractures are tracked via a population registry, and processes and timelines are established for patient assessment and follow-up. FLS programs have greatly reduced the number of costly and serious recurrent fractures by identifying and appropriately treating post-fracture patients, recognizing that this group is at the highest risk to fracture again. There are many reasons for a lack of broad implementation of the FLS in the United States, which include lack of awareness among healthcare professionals that patients who fracture are at highest risk for future fractures, lack of awareness about the successful FLS model of care itself, lack of knowledge about the FLS model of care and how it can be implemented, and lack of tools to implement the FLS model of care. NBHA created Fracture Prevention Central to help address these reasons and provide tools and resources to help implement an FLS. We have over 2,100 registered users to date and are continually adding resources and tools to the site. In fact, Kaiser Permanente has generously shared over 100 of their materials that we just loaded up on the site this past week. As you can see, the major topics covered on Fracture Prevention Central include the impact of fractures, FLS 101, FLS tools, where to start, and reimbursement guidance and business plans. We also cover quality measures, case studies, and quality improvement tools, and have a number of resources. Today's webinar is the 7th webinar NBHA has hosted. We have covered a broad range of topics from implementing a secondary fracture prevention program to making the case, convincing administration to support your fracture prevention program. All the webinars are available on demand, and that is the case for this webinar as well, which should be on demand within the next week. We are thrilled to have you all join us today and hope you will continue to use the site, tune into webinars, and let us know how we can help support your efforts to implement an FLS. We are hoping that today's webinar will be very interactive. The speakers want to share their tools, their expertise, and address the questions and issues you all are facing. So we will be looking at the questions that are coming in, and each of the speakers has built-in time to be able to respond to your questions. We're going to have 3 speakers today. The first speaker will be Ann Lake. Ann Lake is the Fracture Liaison Service Program Coordinator for Wake Forest Baptist Medical Center in Winston-Salem, North Carolina. Ann received her doctorate in nursing and practice from Frontier Nursing University in 2011, with her doctoral thesis focused on implementation of bone health protocols in the orthopedic practice. After Ann, we will be having Brenda Thomason, who is a clinical consultant geriatrics at Kaiser Permanente, Southern California, and Kathy Williams, the Fracture Liaison Service Coordinator, also with Kaiser Permanente, Southern California. Anne will be focusing her talk on the billing and coding aspects of the FLS. I'd like to turn it over to Anne. Thank you.
Thank you so much, Debbie, for that excellent introduction. And I don't mean the introduction of me. I mean the introduction of the FLS program and the platform that the National Bone Health Alliance has set out for us. Really excited about this. Just again, the platform of this webinar is hopefully to bring together the practical real-world tools for the listeners, and hopefully from our experience as professionals with this quality care program, you'll be able to gather those tools that you need to set up an effective and successful program at your institution. The great thing is that, again, all of the resources that we are talking about today and all the information that we're going to give you is going to be available after the webinar, and the NBHA and the National Osteoporosis Foundation are wonderful resource platforms for those tools as well. So we look forward to hearing from you all after the webinar to help get you set up. So the couple of things that I wanted to kind of go over, first of all, as a provider and a program coordinator, my roles are kind of dual in origin, and that means that I actually have to coordinate the program and also see the patients and make treatment recommendations. So some of the common questions that I get are from providers, and so what I want to kind of focus in on are the three main questions that I primarily get. And the first one is about a business plan. The second one is about workflow and documentation, which also has to do with billing and coding. And then the last part has to do with communication and follow-through. So the first part that I want to spend just a few minutes on is the business plan part. So we're looking at what we need in our healthcare reform today, and what that is we're looking at value-based programs, and examples of similar successful programs would be things that we've seen in the past, like programs that identify the patient with diabetes or congestive heart failure or cardiac disease that would be at high risk for other complications because of those diseases. And so this particular program, as you all are aware, is a program that identifies these high-risk patients at high risk for future fractures, and hopefully gets them into a program that will reduce their future fracture risk and overall health risk related to the disease of osteoporosis or poor bone quality. So how do we make our institutions buy into this? The first thing they're thinking about is how do we support this service financially? So what you want to do is you want to have the numbers when you go and you want to present this business plan. So you want to know where you are now. If there's no program in place and you haven't identified that population that you're looking for, you want to do that. You want to set up something similar to what the Institute of Healthcare Improvement discusses about a plan, do, study, and act. So the first thing you want to do is you want to conduct a baseline audit to confirm the care gap. And the way you want to do that is you want to identify simple identifiers of your patients. Look at your patient population, and your patient population should be those patients 50 and over that have had a fragility fracture or have sustained a fracture and are at high risk for a future fracture, maybe based on medical conditions. So you can use date of birth and their fracture code. You can look at maybe x-ray reports, talk to your radiologist, find out how many patients that they've seen that have had fractures they've done fracture x-rays on. Maybe that's a way to track down those patients within your system. So you want to kind of get a firm base of what the gap is. So initially, if you don't have a program at all, then you have nothing. And so you're starting from nothing and you're going to build this program. So you'll be able to see what your care gap is. Maybe you've been identifying hip fractures initially, and now you want to improve your quality of care program by including other fragility fracture areas such as wrist and shoulders and ankles and all those other areas that we all know are potential fragility fracture sites. So maybe you want to evolve that. So you want to find out where your care gap is initially. And then you want to identify and be able to develop possibly a service development team. Find a champion, and that person may be your lead clinician. Like in my institution, I'm the lead clinician, but I have secondary clinicians, the orthopedic surgeons. I have a radiologist that is certified by the International Society of Clinical Densitometry that reads our bone densities. He's a part of our team. You may have a geriatrician or a physiatrist or an endocrinologist or a rheumatologist. You may have a pain management specialist. A nurse practitioner or a physician assistant may be involved. You may have other local primary care providers providers that are interested in being on your team. But it doesn't take a big team. It just takes a strong team, and it can be strong leaders with strong voices in your institution to make this worthwhile and viable for your institution. The key thing is that these services are reimbursable, and we're going to talk about that going further. The next thing you want to make sure is that you have a secure access to the post-fracture patient. So how do you find that out? Well, how do you capture the patient from the ER and get them into your osteoporosis clinic? How do you capture them from inpatient after surgery and get them to your osteoporosis clinic? Once again, maybe you use some of the orthopedic billing codes. Maybe patients are referred directly to the FLS service from the orthopedic service line. Maybe that's where you start. Maybe you look at your rehab facility. Maybe you start getting patients from there. You may have a nurse navigator or a nurse facilitator in your institution that takes care of the orthopedic patients specifically for total joints and maybe hip fractures. Maybe you can have that person involved to help identify these patients. So the key point is you want to identify the patients from ER to your FLS clinic and from inpatient to your FLS clinic. I cannot stress enough to definitely utilize your electronic health records to help with your care coordination, because that's how you're going to be able to measure your value-based program going forward with healthcare reform. So the fourth thing would be, is this service reimbursable? Absolutely. Now, I always say this at the beginning. Always confirm with your billing specialist in your area based on whatever contracts, agreements, or health plans that you may have. You need to ask the question, is your system still on a fee-for-service, or is it now an accountable care organization? Is it an HMO, which is similar to what Kaiser Permanente, how they're set up? They have special contracts, which actually Brenda or Kathy may be able to address as well. But the services are reimbursable. They may just look different from the seat that you are in. So you got to ask those questions with your billing and coding specialist. We're on a fee-for-service. So in our institution, it is a billable service, and we'll talk about what kind of code you would use if you're seeing the patient in a fee-for-service environment. So the next thing you would want to do is, of course, define the roles of your FLS provider, have a simple job description, and all of these tools are available on the National Bone Health Alliance website. You don't have to reinvent the wheel. It's all there for you. You just have to put your tool chest in place. The person who's actually seeing the patient, is that coordinator and the person the same as the provider? Do you have a coordinator and a provider? Are they two different people? What will the provider be doing? And so for me, I'm going to be talking about the provider's role. This is the person that may be the coordinator of your program and your system, and also may be providing fragility fracture care and treatment for their osteoporosis, and that's what I do. So looking at those tools, we've set that out in our institution. So the next common question that I get is related to workflow and documentation. So put it very simply, when I get a patient in our electronic health record, we have an automatic referral that can be put in. It's just an automatic referral that they type into the referral line within our electronic health record, and it says ambulatory referral, osteoporosis orthopedic clinic. And as soon as someone starts typing that, it populates it, and they can put in an appointment. So providers on the inpatient side, the orthopedists as they're getting ready to discharge the patient, or the hospitalists that are getting ready to discharge the patient, when they understand what this program is all about and they've identified that 50 and over with a fragility fracture, they can put in that referral immediately before discharge, and the patient will be set up and put in a pool to be called for an appointment for follow-up. We also do that from the ER side. If they come into the ER, the orthopedist that sees the patient in the ER can generate a referral through the ER if needed on the outpatient side, or when they see the orthopedist first visit in the clinic, after the ER visit, they can generate that initial visit. So I get the patient by referral, outside referral or internal referrals, and when they first come to see me, the initial visit, the template on my appointment slot reflects a 30-minute time slot. If you're going to bill for a 30-minute visit, your template needs to reflect a 30-minute visit slot, because that's what's going to support your documentation. And I am not about to be reviewed by Medicare or any contracted services, and my template says 15 minutes and I billed for a 30-minute visit. So my slot is a 30-minute slot for each of those visits, because that's what it takes for that initial visit, for you to gather the information you need, the history, the bone health history, order the labs that you need, and get a better knowledge of what that patient's bone health history is. It really does take about 30 minutes to do that. So you need that dedicated time, and your template needs to reflect that. That visit would be a 99214 visit. If the patient is in orthopedic clinic and being seen by an orthopedic provider in the Fracture Liaison service, you can bill a 99214, but if they've had surgery by one of your orthopedists, then you would want to use a modifier 24 along with that 99214 code, as long as they are in what's called the global period. We can do some clarification with this after the webinar if needed, but most of you probably have a general understanding of what that means. So that initial visit is a 99214 with a modifier if appropriate, or a 99214 initial visit if they are not in a global period. The follow-up visit, the template will reflect a 15-minute time slot on my schedule, and the template, the follow-up visit template reflects that as well. So what we've done is I sent a copy of my templated documentation into the National Bone Health Alliance, and Ms. Zeldo has a copy of both the initial visit template and the follow-up visit template that I utilize here at Wake Forest Baptist in the orthopedic department. It's not a copyrighted template. It's just a standard template, but it covers all the things that you would want to cover in either an initial FLS workup or a follow-up visit workup. So, and that visit would be a 99213 for your follow-up visit. Again, a modifier if they're still in the global. If not, then just the 99213 visit. And your documentation should always reflect based on how you are billing, so you are appropriately coding for that visit. So just to kind of wrap things up and then to leave a little time for question and answer, the final thing that I get a common question about would be about communication and follow-through. So what does that look like? Well, as a provider, depending on the patient's disposition, my patient may leave the hospital and go home. My patient may leave the hospital and go to a skilled facility. They may leave the hospital and go to a rehab facility or a long-term care facility. It really depends on what the disposition of the patient is as to how I might need to navigate through getting them on a treatment plan and also communicating with their other providers. So at some point you may need to generate a letter to the primary care provider or the geriatrician, or maybe a letter to the medical director of the skilled or the long-term care facility for the patient that you're actually treating if you are the provider treating that patient. So what happens is when I see a patient on the initial visit, I find out where are they residing. Are they at home? Are they in a long-term care? What's happening with them? And I determine who do I need to communicate with. And what do we call this? We call this care coordination or coordinated care. And this is what's going to be required as part of our value-based system in healthcare reform. So if we are all familiar with what that means, it means that we have to actually communicate with one another. What a novel idea. Isn't it great? And it also helps with continuity of care for our patients. So, for example, if I'm ordering a new treatment and the patient resides in a skilled facility, not only do I make a note for the patient to take back to the facility, because they always come in with those little notes and we have to write a little note on there or maybe send a new order with that patient, but I either myself or my assistant will call the director of nursing of that facility or of that rehab facility and make sure that they are aware that I'm starting a patient on a new treatment for their osteoporosis, and of course that we're recommending falls prevention, personal safety, and that we've developed a plan of care for their patient to reduce their risk of future fractures and falls. The institution they are so appreciative of this because they actually want their patients to stay healthy and they want to keep those patients. And so we want to help them do that, and they do appreciate the communication. But if you don't have the time to call, just make up a templated letter. There's also letters out there. I know that Kaiser will show you, Kathy or Brenda will show you one of the letters that they use. very, very helpful. Don't have to reinvent the wheel again. You've got a template there if you need it. And then the thing that I want to cover as a final note would be certain medications that you may order as a provider. You may actually have to deal with either Medicare Part B or Medicare Part D plans. So let me just make the point. Always understand whether a medication is going to be covered by either the Medicare Part B or whether it's going to be covered by the Medicare Part D plan. Make sure that you kind of have a general understanding of that before your patient comes in or when they come in or before you're going to start therapy on them of some kind of treatment if they need prescription therapy. The reason you want to make sure that is understood is because patients will get calls. They'll get calls from their insurance company and maybe some specialty pharmacies. And sometimes that can actually be just enough to scare the patient away. They're confused and they don't know what to tell people. They don't know how to talk to people. So they may just not do anything at all. So I try to make it easy, and I try to have them understand that at the beginning. And so if I understand what plan that their medication may be covered under, I can follow up and make sure that if they need a specialty pharmacy, that I'm working with a specialty pharmacy. If I need to talk with the pharma representative for a particular treatment that I may be using, I'm going to talk with that representative because they may have some tools that I need to make sure that this bridge of care is very, very smooth for my patient. Because once they get on a medication, it needs to be smooth for them to be able to stay on that medication. And if we make it easy for them to start, it's going to be easier for them to remain compliant because they understand that we are involved in the totality of their care. So knowing this up front and having a plan will help the patient compliance and overall success of your program, avoiding unnecessary delays in treatment initiation if needed. So at that point, I'm going to kind of wrap it up and just say that we've covered some implementation strategies about a business plan, workflow and documentation, and communication and follow-through. A lot of this information and some tools that you may need are also available on the National Bone Health Alliance website. Debbie, Ms. Zeldo has my contact information. Certainly glad to help anybody on a one-on-one if they have a specific question. But for right now, I want to open it up and see if there's any questions and answers in the little queue here. And what is the maximum number of patients that I can see and care for in one day? Interesting. So because I'm part administration and I'm also clinician, I have to share my time. At this point, let me tell you what my clinics look like. I have a clinic on Monday afternoon, which if I have initial visits that are 30 minutes, you can kind of calculate that. I start at 1 o'clock and I work till 4:30. And so if I have initial visits, if they're all initial and they're 30-minute slots, then you can kind of calculate how many that would be. So I have clinic on Monday afternoon. I have clinic on Tuesday mornings from 8 to 12, and then I have clinic all day Wednesday. That's my longest day. And if you calculated the 30-minute appointments and you intermingle some 15-minute appointment slots along with some nurse visit slots, you can get about 20 or so patients in a day for the FLS service, and that's on a full day. If you adjust your appointment slots a little bit and you have some nurse visits for some education and those kind of things, or maybe medication administration, you can probably see a good 10 or 11 on a half day. So I do Monday afternoons, Tuesday mornings, all day Wednesday, and then Thursday mornings. But certainly enough to support a full-time provider doing full-time clinic. We have a large institution. We did over 4,000 fractures last year, and so it's a large academic institution. But once again, if you know your numbers, you'll be able to calculate what kind of support, whether it's an FTE or a part-time clinician and maybe coordinator role that you may need. And then I've got, let's see, another question here. Do I ever see patients when they are in the acute hospital setting? Great question. Yes, you can see the patient in the hospital setting if your schedule will allow. Unfortunately, again, as coordinator and provider in the outpatient clinic, it's hard for me to get over to the campus a lot of times, although it's just across the street. However, there are programs across the country that have inpatient nurse practitioners and physician assistants in orthopedics that will actually see a patient in the hospital as part of the FLS service model. hospital, and that is a billable visit in the hospital, and they can see them for their osteoporosis, initiate the visit, and then refer to me on the outpatient side. But yes, I do see patients in the hospital on occasion, but there is the possibility of having that type of program set up where the patient can be seen in the acute care setting. It's a billable visit, and also on the outpatient setting as well. I think I have time for maybe one more question. What have been my major obstacles with patient compliance, and what are my solutions? Okay, so the major obstacle with patient compliance is if the patient doesn't get enough education about the FLS program at the beginning, then what happens is they don't understand the importance of them being involved in this specialty program that is really population-based for them because they are a fragility fracture patient at high risk. So if they understand how important this program is and you have orthopedic support, the orthopedist has actually fixed that fracture, and the orthopedist can say to the patient, or part of the orthopedic team can say to the patient, we have a special program for you called the Fragility Fracture Program or your Fracture Liaison Service Program that we're going to put you in. And we have a video that a patient can see before they leave the hospital, similar to some of the cardiac rehab videos that used to be, the patient would have to see the cardiac rehab video before they left the hospital. Well, we're in the process of sort of mandating that a patient see this video before they leave so they understand when they see me on the outpatient side, that's what this service is all about. So patient compliance is excellent when they understand that you're, number one, going to help improve their quality of care by improving their bone quality, but also you're going to help improve their quality of life by reducing their risk of future fractures. So the solution is adequate patient education both on the inpatient side and, of course, on the outpatient side. So we have a folder that we use that we give the patient that's got a lot of information in it. And then, of course, adequate communication with your patient. If they understand that you really want them to have better health and absolutely help decrease their risk of future fractures, then they're likely to be more compliant. And then if you understand about their cost and what their insurance plans are going forward and you can talk the language and help them understand that, that's going to help reduce a lot of their anxiety and help with compliance as well. Unfortunately, I have to wrap it up, so I won't be able to answer any more questions, but we'll be glad to take a look at these questions. And Debbie, if you can kind of maybe jot some of these down, we might be able to answer some of these and put them on a frequently asked questions flow sheet or something that can be accessed after the webinar. So on that note, I really want to thank everybody for my time to be able to present to you today. And I see a lot of colleagues on here. I'm so excited. And get your FLS programs going. All right. So I'm really excited for everyone. And take care of those patients and hopefully you can give them a break-free future. And I look forward to speaking with you all again sometime. Thank you so much. Debbie, I think I'll turn it over to you, and we'll go right into the next section. So is that Brenda or Kathy? Which one's on? Brenda. All right, I'm going to turn it over to you, my friend. All right.
I think Brenda's not here just yet, so I'll take over for Brenda. And I'm going to bring up my slides. I'm going to spend a few minutes talking about the nuts and bolts of our program, which is our education piece. And I'm going to give you lots and lots of information in this short period of time today. But I want you to know that we'll be meeting like this monthly. So if there's more that you would like to discuss with us, we'll be doing this every month, and our contact information is available for you today. What I'd also like to suggest to you today is to learn from our experience. Like Ann just said, don't try and reinvent the wheel. Programs have been figured out for you already. Education materials and handouts for your patients and providers, patient letters, phone messaging scripts, and more that we know work are already available for you. We've been doing this for a long time at Kaiser Permanente. You just need to find what will work for your hospital or your organization. Now, today we'll be talking about our Healthy Bones Program tools, which, as was mentioned earlier, have been uploaded to the National Bone Health Alliance website. So we'll walk you through step by step exactly how to access our tools on the National Bone Health Alliance website. And it's very simple, very easy, and I'll show you exactly how to do that. We try to keep our providers well educated about all the current hot topics and issues that are going on and keep them informed about osteoporosis awareness. On the screen in front of you is an example of documents that we've created. One of the documents are the common facts, figures, and statistics that are frequently quoted by us about osteoporosis and fractures. That was requested by our Healthy Bones Care Managers. Our Healthy Bones Care Managers are physicians, assistants, and nurse practitioners. There's also a sample up there of the ISCD, which is the International Society of Clinical Densitometry Training, and we provided that for our providers. We create brochures and posters for lectures and health fairs that we give. The one on this slide explains our Healthy Bones model of care, and there's actually a matching poster, which is a nice display for a conference a provider may be attending. We provide 3 main sets of working guidelines: our Kaiser Permanente Clinical Practice Guidelines, the National Osteoporosis Guidelines, and our Healthy Bones Care Manager Guidelines, which are the ones we tailor especially for our nurse practitioners and physician's assistants. We provide FAQ sheets, and these answer frequently asked questions about individual topics, and those are usually whatever is the current or hot topics, such as atypical femur fractures or IV medication for osteoporosis. Up on the screen, you'll see a Z-score on a DEXA. We found that a lot of our providers didn't actually know what Z-scores meant. These would all be examples of some of our FAQs. We provide job aids, which are step-by-step guides for carrying out a process. As an example on the screen, you'll see a FRAX decision tree. Many of our job aids are in the form of decision trees or workflows, and they're very easy to follow. We use every opportunity and every point of service to outreach to our patients. At Kaiser Permanente, we use electronic medical records, and we use every one of those opportunities. But even if you don't have electronic medical records, we have opportunities with letters, phone calls, automated phone messages, and we can make you aware of all of those. We encourage this month, the month of May, which is National Osteoporosis Awareness Month, as a time to increase awareness, and we do that at our medical centers, and we send out ideas. We usually have 1 week in May when we try and all participate in an osteoporosis awareness event together. We provide many education handouts, and we have a CRAMES booklet. CRAMES has customized a booklet just for us, and we cover many education topics such as calcium, vitamin D, fall safety, how to have healthier bones. These are some examples you'll see on the screen in front of you. The National Bone Health Alliance, like I said, has uploaded all of our materials. There's lots and lots of materials for you to look at. I'll show you today just how easy it is to access these materials. And what you can do is customize them for your own organization or hospital. So what you can do is simply remove our name, Kaiser Permanente, cut and paste your name, and you're good to go. Similar to our provider frequently asked questions, the FAQs that I just mentioned about current hot topics, we also provide the same for our members. And you'll see some examples there on the slide in front of you. We have found that having consistent member communication that comes from each of the programs at each of our medical centers is most effective. As a result, we created standard patient letter templates for the Healthy Bones Care Managers and our primary care providers to send to their patients. They also have coordinating what we call after-visit summaries, and these are given to the patient as a piece of paper after their visit for them to review and look over when they get home. And these after-visit summaries are also available online. What's nice about these letters is that they're very simple and very easy to understand, which is what you want for general member comprehension. They also have been approved from a legal standpoint. And then for our automated phone message system, we also have created scripts for those recordings, so that's something that you can also use. After last year's ISO meeting in Chicago, I'm not sure how many of you were there, but Brenda and I came away with many new ideas. But we especially liked the idea of using decision aids to help people make decisions, especially making decisions about whether or not they want to take medication. And this came from Dr. Michael Lewicki's talk. So I'm going to show you a couple slides showing what decision aids look like. So as an example, you may notice that a lot of people come in and they don't want to take medication because of osteonecrosis of the jaw. They're afraid their jaw will fall off. They don't want to take medication because of atypical femur fracture risk. They're afraid that they'll break their leg. What we've done, and this was from Dr. Lewicki, is created decision aids, and we show the patient if you have all of these people, this one little teeny tiny green face here is your risk of having an atypical femur fracture. This little teeny tiny blue face is your risk of having a jaw problem, so that they can put into perspective how rare it is, how uncommon it would be for them to have this problem happen to them. The next slide shows the risk of a woman after the age of 50 suffering a fracture if she didn't have treatment for osteoporosis. So they see all these red faces, and we make those faces a little bit sad where the other ones are smiley. And they see that it's very, very important that they need treatment for osteoporosis. We also have the one that talks about seat belts. If you ask someone if they'd ever go driving without a seat belt, they'd say, oh, absolutely not. Well, we relate the same car accidents, injuries, and deaths to osteoporosis, and you wouldn't want to take the risk of having a fracture without treatment for osteoporosis. And the last one, oh, it's not completely on. You can't see the slide completely. I can't see it from mine, but hopefully you can see the entire slide. But what it shows is your risk of other complications. So it would be things like being killed by a car accident, being murdered, dying from drowning, and those are great big risks compared to osteonecrosis of the jaw or atypical femur fracture, and those are teeny tiny risks compared. And it puts it in perspective for them, and so then they're not as frightened. And these decision aids really, really help patients make the decision to take medication. They're very, very effective. Now what I'd like to do is help you, just walk you through step by step how to access all of our materials on the National Bone Health Alliance website. It's very, very easy to access these materials, and what I'd also like to do is just stress what a wealth of information is located on this excellent site. For those of you that haven't already taken a look at the National Bone Health Alliance website, plan to take an extra few minutes when you go there, like pour yourself a cup of coffee or a cup of tea and peruse the great information that they have on this site. This is a gold mine for those of you that are starting up your FLS program. When you go to the nbha.org site, you will first need to create a login. Very quick and easy, no cost, no commitment. You just enter your email address and a password. Now you're going to click on the NBHA carousel link, and this is all just the yellow here. It's made very easy for you. And then click on the link that says Read More. The next step is to click on the new Kaiser Permanente resources available for download area that you see highlighted with the purple area. And then again, click on the area that says Read More, and that's the purple area on your left. From there, you're going to click on the area you're interested in opening. Now, each one of these red areas are zipped files. In other words, there are other documents inside each of these areas. So if you're interested in member education, if you're interested in provider education. When you click on that, there will be other files inside of there. Now you're going to click on the word zip. Be patient as it takes just a second to open this file. Most of you will now look for another area in the lower left-hand corner of your computer screen to now open. If you have an older version computer, you may need to unzip this file. And this will all make sense when you go through it step by step. Now you're ready to pick and view the document from the list of files in the folder. And what you do is you just click on the file of your choice. You can read it, you can save it to your computer, you can print the document. Don't forget you can adjust it for your organization, so you can delete our Kaiser Permanente name, you can copy and paste your hospital name, and you're ready to go. So as an example, the first one says member, 3 steps for healthy bones. English means it's in English, Spanish means it's in Spanish, Chinese means it's in Chinese. So we have, for a lot of our documents, multiple languages. You would click open that file and see exactly what that file is. I just have one more word of advice. For those of you that were at the recent New Orleans conference, there's something else that Brenda and I shared. At Kaiser Permanente, we save 1 hip fracture for every 100 patients that we treat. Here it costs us about $35,000 for each hip fracture, and I think that's comparable nationally. So if you only look at the economics, that's a lot of money saved. This alone, I think, is convincing enough to start a program. At Kaiser, we've saved 1 life for every 25 hip fractures avoided. This is priceless. And the one thing we don't always talk a lot about is the member independence that we preserve, and that's also priceless. My own mother has severe osteoporosis, and she's fallen more times than I can even begin to tell you. But she's in one of our Healthy Bones programs. And even though she hasn't always been compliant with her medication through the years, we've managed to prevent a hip fracture and keep her independent and in her own home. She's 87 now, and to my own family, that's invaluable. So I want to thank you for your time and attention. Here is all of our contact information. A lot of you know Dr. Dell. Brenda, unfortunately, wasn't able to get on the line, but this is all of our contact information. Let us do what we can to help you. Like I said, we've been doing this for a very, very long time. We not only know what works, but we know what doesn't work. So if there's something that you think, oh, maybe we should try this, go ahead and drop us an email, and we can say, oh, that's a great idea, or we can say, oh, we tried that. That didn't work. So questions? I could take questions now, unless Brenda's on the line and Brenda has something to say.
Brenda has not been able to join us,
Okay.
Kathy.
All right.
And for our participants, as a reminder, to ask a question via the web presentation, simply select the chat pod in the lower left corner of your screen. You can type your message in the text box and then click the send button.
Since we have a little bit of time, I'll go ahead. I see there's still 2 questions in the queue. This is Ann Lake, and there was a question about what are the pros and cons of setting up a follow-up in a private clinic versus in the hospital setting. Just for clarification reasons, I'm not exactly sure I understand about the follow-up part, but I think what they're talking about, what they may be asking is, if you identify the patient and they're in the hospital and you actually see them in the hospital initially, then that gives you actual time to gather the history on the patient. A lot of times those patients, of course, are sedated. They may be on pain medication, so you're really doing a lot of chart review at that point. You may be talking to family members. If there is a really good electronic health record system set up or electronic medical records, you may be able to track down a recent bone density test. Those are the reasons that you would also want to see the patient in the hospital setting. But the main reason, if you can is to at least capture the attention of the patient while they're in the hospital, leave some material behind about the FLS service so that they understand that they're going to be crossing the bridge from inpatient to outpatient and being put in a special program just for them to help reduce their risk of future fractures. Now, in private clinic, obviously the billing is going to be different versus in the hospital setting, but I hope that maybe answers that question a little bit. The main pro of seeing the patient in the hospital would be that you can get do earlier education, and research has shown that, of course, the earlier you begin teaching the patient and they understand the improved compliance there is. The cons are, of course, the convenience of having to go to the hospital unless you have part of your healthcare team has an inpatient side. Setting in the private practice or private clinic, patient can be seen by the orthopedist on the same day as well as the FLS service provider if they're in orthopedics, and it's still a billable visit, so it saves time for the patient. That's one of the advantages there. I think, let's see, another question was, how do we identify functional risk for fracture? Great question. I've seen functional risk mainly be used on the prevention side, and there are some wonderful programs out there that can actually do a great measurement of functional risk. There are some physical therapists and occupational therapists that use some quantifiable tools for that, but as far as this particular program, I have them go to the physical therapist and let them do, of course, their falls prevention evaluation or what their risks are for balance and core strengthening concerns. But on my side of the Fracture Liaison service, we have not actually implemented a functional assessment tool for this particular program. Certainly something that would be a great addition, so that's something to consider down the road. Let's see. I was going to see. Do you see any questions that you might want to answer?
I'm good here.
Kathy? Okay. I didn't see. Okay. Do I run a registry? Okay. Well, at our facility, we use our EHR to track down the data. We have analysts that actually track our internal data. We have not at this time started using a registry that would help compare us with other institutions across the country, but I do believe that is something that's going to be trending. There is a wonderful program that's out there now that is going to be something that we're going to be looking at. Once again, a lot of these programs can be very costly. Sometimes it takes grant money to get these programs, but
actually, I was just going to jump in if you don't mind.
Yeah, go ahead.
This is Debbie from NDHA, and actually we are going to be launching a registry within the next couple of weeks that was actually just approved by CMS as a QCDR. So that will make it even more impactful in terms of reporting for PQRS and other meaningful use measures. But to take a step back, it is going to be a registry specifically tied in with fractures, FLS, and osteoporosis, and we will definitely be sending information out about that in the near future.
Is that going to be a free program for everybody, or is it going to be a cost to the institution for implementation, or do you know those details yet?
Yeah, right now it was actually just posted on the CMS site. There is a nominal fee for the institution to be able to use it. Because
I know one of them is around $2,000 at this point, so that was a little bit for us, but that'd be great. I mean, we need something like that, so something to be looking at. I know Wake Forest will be looking at that as well. Thank you, Debbie. I appreciate that.
Great.
Let's see. I was looking to see if there was any more. There's a question that says, in Kaiser, when a patient has a fracture, who orders the labs and does the workups? Do you want to answer that one?
Yes, our Healthy Bones Care Managers, so that's our physician's assistants and nurse practitioners.
Mm-hmm. Okay.
So for us, it's like a one-stop shop. After the patient has the DEXA scan, they go to the nurse practitioner or physician's assistant, and they do everything for them. They review the DEXA scan with them. They prescribe the medication. They order the labs. They give them a little bit of education, and then the follow-up labs are done by them. So everything is done right there, and especially for our elderly patients, that's such an advantage, because to get them to come back for another appointment, especially with transportation issues, that's not always convenient. So we've found this model of care has been very effective.
And somebody asked who created the patient video and who's responsible for assuring that the patient views this before discharge. If there's a nurse navigator or a nurse facilitator on the floor, they can do it. If there's actually if they have a central video system, they can do it that way. The video was created here at Wake Forest, but there is a generic video that the National Bone Health Alliance is going to have available. So I would check with the National Bone Health Alliance about that generic video. It's about a 2 to 3 minute patient video. It's very easy to understand, and it actually is in English and Spanish. So Debbie, you might be able to help some people, providers, if they're interested in getting that video. But that will be available through the NBHA if you're interested in having that video for your institution. I think there's one more question on there that you might be able to answer, Kathy, and it was, it actually said, would you mind going over briefly again about how to access the Kaiser information?
Sure, and I can go back on, let's see,
and that should probably wrap us up if you got to that.
I'll just go back on the slides here real quick. It's very easy to do. What you need to do is create a login. You put your email and a password. You go to the nbha.org. You put that in your browser, and it gets you to the National Bone Health Alliance website. You create a login. So you put in your email address for a username and then create a password, and that will get you into the site. And that's no commitment, no cost. And then when you get to the NBHA carousel, you're going to click on fracture prevention. Everything is actually, when we're finished, if you, under presentation, click on the KPS Cal Fracture Prevention Central slides, everything will be here for you. So you're going to go to the NBHA carousel, and you're going to, the first on the right-hand side, click on the carousel first, and then click on Read More. And from there, you're going to click on our new Kaiser Permanente resources available for download site, and then Read More. And then our Kaiser tools. Now, our Kaiser tools, the way it's listed, these are the different areas. Keep in mind, inside each of those areas are multiple documents. From there, you click on the area that says zip, and this is a zipped file, so it just takes a hot second for that to open, so be a little bit patient. Now, most of you, when you click that on, in the lower left-hand side, that's where you open your document. For some of you that have older computers, you might have to unzip that file. And then from there, all the documents will be inside there. So some of those files are larger than others, but you will see all the documents from there. Keep in mind that many of the documents are offered in multiple languages, but what you do then is click on the file you'd like to look at. So as an example, the first document there is a handout. It's 3 Steps to Healthier Bones, and this is a handout that we frequently give to our patients. As they've seen the Healthy Bones Care Manager, there's a little spot that they can write in the medication that they're going to take, and it talks about calcium, vitamin D, exercise, stop smoking. It's just kind of a general how to keep your bones healthy. So each of these zipped folders have different information. So one might be member education, one might be provider education. There's one file that has articles that are good ones if you're starting up a program. Each zipped file has different information. Inside the zipped folder are lots and lots of documents. Okay. And keep in mind, in the site itself, the NBHA site, there is so much information for those of you that are first starting a program. There's business cases. There's just step-by-step how you start a program. It's an excellent website to look at. So give yourself some time to go through the entire website.
I agree.
Yeah, and thank you. And as everyone had mentioned, we are going to be doing monthly discussions, so we'll be able to continue to share the resources and ask and answer questions that everyone may have.
Right.
Great. Well, thank you, everyone, for joining us this afternoon. We do hope you'll spend some time answering the evaluation that you'll be receiving right after the seminar ends, and we will send a follow-up with some of the links that questions were asked about, as well as Anne's great suggestion about developing an FAQ on all the questions that we had. Thank you so much for your time, and we look forward to having you join us in the future.
Thank you. Have a good day.